You're at the cutting edge of cardiovascular sciences. I'm John Cook, professor and chair of the Department of Cardiovascular Sciences, and today we're going to have a really interesting discussion about the interface between clinical imaging of peripheral arterial disease and AI-mediated merging of data sets, spatial transcriptomics and histology with that clinical imaging. And here to introduce our guest, faculty member Dr. Li Lai.
Today, it's my great pleasure to introduce our colleague scientists, Dr. Tricia Roy and Dr. Guangyu Wang. Dr. Guangyu Wang is Associate Professor at Weill Cornell Medical College and the Houston Methodist Academic Institute and the Director of the Center for Bioinformatics and Computational Biology. With a background in mathematics, he got his PhD in bioinformatics in Beijing Institute of Genomics in China. Then he did his postdoc in Boston Children's Hospital. In 2021, he's recruited to our research institute as assistant professor and now associate professor in Department of Cardiovascular Sciences. His pioneer work includes the development of deep learning frameworks for intercell phase transition from single-cell RNA sequencing, which are published in Nature Biotechnology, Nature Method, and Nature Communication. And his work is also supported by NIH, R35, and R1 awards. His team also extensively collaborated with other research teams and published in high-impact factor journals, including Circulation Research, Nature Metabolism, etc. Currently, his lab focuses on building multimodal AI foundation that integrates spatial transcriptomics, histopathology, imaging, and clinical data to advance disease diagnosis and prognosis. Then our other colleague scientist, Dr. Tricia Roy, is a vascular surgeon scientist and associate professor at Weill Cornell Medical College and Houston Methodist Academic Institution as well. She got her MD and residency in vascular surgery from University of Toronto. Then he got recruited by our hospital and became assistant professor and now also associate professor of cardiovascular surgery. Dr. Roy directs the Peripheral Vascular Translational Imaging Laboratory and recently founded the Houston Methodist Peripheral Vascular Device Core, which is the only facility worldwide utilizing proprietary MRI techniques to analyze complex disease in actual patient limbs. Dr. Roy's research is supported by NIH and AHA, which combines material engineering, advanced MRI techniques, and clinical practice to improve outcome for patients with complex vascular disease. So welcome both to our show.
Welcome, Dr. Roy, Dr. Wang, to the show. Two very different fields you're coming from. And when interesting things happen at those interfaces between two very different fields. Tell us a little bit about how you got together and how you began to learn each other's language to start collaborating.
So I think we first met was at the DeBakey CV Research Day that started up, and so it was really a nice platform for everybody to kind of introduce their research. And I'll admit, when I saw Dr. Wang's presentation, a lot of it went over my head, but it was clearly transformational. So that's where we started to talk a little bit about where we could intersect and use my imaging in combination with some of the amazing techniques he'll be discussing.
Yeah, in that research day, I think Dr. Roy present how she can first have the MRI image of the imputated leg and also get the histopathology image, and the tissue is already there, and we can further using the spatial transcriptome to sequence the tissue, and then that be a chance for us to incorporate different information, including the MRI image and the histopathology image and also the spatial transcriptome. So that is how we start the collaboration.
I'd say I'm proud to be your colleague. You guys are amazing in your own fields. I mean, you are a busy vascular surgeon. You also find time to do research, interventional research, trying to understand how devices interact with tissue. And you've developed a very unique laboratory, core laboratory, to do that. Tell us about your core laboratory.
So yeah, I'm 50-50, so I do have dedicated research time, which is great. And when Dr. Lumsden brought me on as a surgeon scientist, it was the first in our department, and it's just been a really, really unique opportunity. But yeah, the PVD device core, one of the issues is that whenever we're having a lot of these devices, they're only tested in healthy animal models, and that's not at all reflective of the disease we're treating. And as a result, we have these really significant complications that have been coming out. We've had multiple device recalls of things that I use every day. And so that was really, really, eye-opening. So the fact that we have this existing pipeline where we're imaging amputated legs and doing interventions just as you would in a very high fidelity setting, now other companies are also wanting to use that to be able to understand how their devices are working and how we can make them better for the next generation.
Wonderful. And Dr. Wong, you're doing some amazing work merging data sets, spatial transcriptomics and histology. I understand with your program, Thor, you can actually look at a histology image now and understand the transcriptome of every cell in that image. Amazing.
Yeah, that is our new technology. Actually, we train our own generative AI model, like how OpenAI trained the ChatGPT. So the idea is, so when you ask AI to read the image and also the transcriptome paired data, so they read them again and again, so they will remember the information from two different modalities, one from image and another one from transcriptome. And later, so they can calculate the similarity across two modalities. So previously, we can calculate the similarity between two images and two transcriptome. But now we can calculate the similarity between the transcriptome and the image. So in this way, we can bring them together and let the AI to predict the transcriptome from image. So.
Wonderful. Well, hold on, folks. We're about to go on an intellectual roller coaster ride, starting with Dr. Guanyu Wang telling us about his amazing technology to merge spatial transcriptomics with histology and imaging.
Yeah, hello everyone. Today I will present how we developed the AI technology to merge the histopathology image and the transcriptome. So the reason why we want to develop this technology is because in the clinic, so they will not, so when a patient comes to hospital, so we will not always sequence the patient. So actually that is very rare. But in most cases, we will gather pathology image and with cellular morphology and tissue morphology information. But now we try to train an AI model that can predict the transcriptome from the image. So if we can finish this project, so after a patient comes to the hospital and then we gather pathology image and then we predict the transcriptome and start to analyze the molecular information that can enhance our diagnosis and prognosis. So this is a kind of timeline for us to develop different technology from different sequencing technology. So we can see several years, around 10 years ago, so actually I'm studying the bulk level sequencing, mainly focused on RNA sequencing. So at that time, so actually not a lot of single cell RNA sequencing or no spatial transcriptome has been done. And several years later, so I start to study the multi-omics data, but still at bulk level. I mean, we can study the RNA-seq and paired with ATAC-seq or ChIP-seq to understand both the epigenetic regulation and the transcriptome change that can enhance our understanding of cell identity and cell phase transition. And later, we start to analyze the single cell level data. At the beginning, we start to analyze the single cell RNA-seq data. So using this kind of data, we can understand the cell population. That is the first. And most important, we can also understand how a cell becomes to another cell. So using the single cell RNA-seq data, we developed a technology named cell dancer using RNA velocity framework that can predict the cell phase transition. And then spatial transcriptome has been developed, and we start to analyze cells and tissues with spatial information. So with the spatial information, so actually we can study the microenvironment from the tissue. For example, if a cell has sending out the inflammatory signal, and the immune cell should come and clean the so probably it's a kind of tumor or some other things. And this kind of interaction should only be analysis with the spatial information. So we can understand how, which cell co-localize which cell, and how a cell send out the signal, and another cell receive the signal, and the cell communication. But actually, there are more things we can do with spatial transcriptome, because when we prepare the data set, so we will cut the tissue into multiple adjacent slides. So one slice will send for the spatial transcriptome sequencing, and another one will send for the pathology staining or any staining. So in this way, you can have a paired data with imaging information and with transcriptome information. So we decided to train a model that can bridge these two information together. So if we can do this, it means we can somehow transfer the molecular information to the image, and then make a bridge between the genomics to the clinic, because actually the image is the one we are using in the clinic. So we developed several different platforms, one named SUR, another one named Loki, and both of them published this year, one in Nature Methods, another one in Nature Communications. Actually, here is a kind of different skill of what we try to do. If we talk about the pathology image, we have 3 layers of the image. So the largest one is whole slice image, indicated how the patient tissue looks like, and then the tissue patches, several cells co-localized together that can reflect the tissue microenvironment, and then it is a single cell resolution that can reflect how the cell looks like and which transcriptome this cell has. And if we talk about the omics data, so at the whole slice level, actually that reflects the whole patient. So at the patient level, we have the bulk level RNA sequencing, attack sequencing, whole exon sequencing, whole genome sequencing, and cut and tack sequencing, different level of for the patient sequencing. And if we talk about the tissue patches, we have spatial transcriptome vision technology, and also spatial metabolomics, also at the tissue patches level, and also the spatial epigenetics, so we can sequence cut and tack, and also the chip-seq at the spore level, at the tissue patch level. And if we look at the single cell resolution, we have the single cell RNA-seq data, we have the single cell ATAC data that can be used to analyze the chromatin openings, and also the single cell proteomics data, and the single cell level spatial transcriptome data. All these kind of things can be used to analyze the cell. And the AI technology we are working on is we try to develop different skill of multi-modality AI platform, and also develop the application using based on this platform. And also we try to reconstruct 3D tissue and analysis cell interaction, tissue microenvironment at 3D level. For example, in Dr. Roy's study for the PAD disease, peripheral artery disease, actually we want to analyze the vascular, but if you use 2D space to analyze vascular, actually the information is very limited, so you can observe a circle like vascular, but actually vascular is a 3D, has a 3D structure. So we need to reconstruct the 3D tissue first, and then study the vascular. So that is, I think Dr. Roy will show some new data. So we did together. And also, we try to develop the AI platform that has a reasoning capability like ChatGPT, but that should be fully focused on biomedicine. And also, we try to infer the drug response and also the vaccine response, and develop several new technology to screening drug and vascular. So here I will show you some new data. So new platform we developed. So one platform we developed is named Loki2, and actually we published Loki1 this year, but Loki1 is at the tissue patch level. So in the tissue patches, we will Loki1 can tell you which tissue this patches is. For example, it is a normal tissue or vascular tissue or muscle tissue, but actually that is not the single cell resolution. So in the version 2, we try to focus on single cell resolution tissue analysis, and so we developed the version 2. So we segment the tissue first. In the tissue, we segment all the nucleus, and then we train the model from the nucleus morphology, we train the model to predict the cell type and also predict the transcriptome. So that is kind of very popular technology recently named self-supervised learning. After the model trained, if you give me a pathology image, we will identify all the cells on the image and determine what is the cell type for every cell. And also we can, so in this figure, so we showed how you can segment the cell and how the cell colloquize together. And later, after we develop the cell segmentation model, we can actually predict the transcriptome. So the idea is we can calculate the similarity between a cell and a transcriptome by training another AI model. So after the AI model trained, what we did is you give me a pathology image, we segment cell on the pathology image, and then ask the AI how to pair every cell on the pathology image with a single cell RNA-seq data. There are a lot of cells on the single cell RNA-seq data, and there are another set of cells on the pathology image. We try to match them together based on the AI model. So in this way, we can predict the gene expression for every cell observed on the pathology image. So here is some example data. So in this data set, actually the input data is a pathology image. And after running our model, so we identified every cells on the image from the single cell RNA-seq data. Actually, basically, in the single cell RNA-seq data, there are a lot of cells. Every cell has a whole transcriptome information. So what we try to do is try to put the cell from single cell RNA-seq data on the image. And we calculate the correlation between the ground truth real sequencing data and the predicted data. I didn't show you the results here, but the results is based on our benchmark for the top 100 highly expressed genes. The Pearson correlation is over 0.7, highly correlated. And so that is the first platform. So we try to deliver next year, early next year. And another one is the whole slice level platform. So the platform I just showed you is single cell resolution. The next one is whole slice level. So what we try to do is when you give us a whole slice level image, so we will convert the whole slice image into a high dimension vector. Based on that vector can represent the tissue morphology from the patient. And based on that tissue morphology, we can predict what is the disease for the diagnosis and prognosis, and whether this patient has a mutation, for example, if the patient is a tumor patient, and whether this patient should respond to some drug. I showed you two Nature papers published last year. So one named Chief, another one named Gigapath. Both of them focus on whole slice level prediction. And we develop our own model named Fuji. So the idea is when we put image into our model, it will be converged into an embedding space, and we ask the AI model to convert it back to an image, to reconstruct the image, and to reconstruct the transcriptome, and to reconstruct the mutational signature, which is a kind of technology for the mutant genesis. If the AI can do that accurately, it means the embedding space generated by the Fuji is very good. So we benchmark our Fuji with two Nature papers based on several different tasks. Here I show you the MSI, which is very important for the tumor patient. You can see the prediction using our model is the AUROC is around 0.7, but two Nature paper is around 0. Our is around 0.9. And there is around 0.7. And we can also predict the tumor mutation burden. And so no matter the burden is silent tumor mutation burden or non-silent tumor mutation burden. And we can also predict the neoantigen SNV have higher resolution occurrences than the two Nature paper. So that is the technology we try to develop, and that is focus on. So my part is focused on the transcriptome and histopathology, and we also collaborate with Dr. Tricia Roy to develop another set of AI to bridge the HE staining image and the MRI image and the transcriptome together in PD disease.
Wonderful. You know, one of the things that occurred to me when you were showing us the data with tumors, the ability to understand on a histology slide what the identity is of each cell in that. If we can apply that to Dr. Roy's imaging, we might be, and I'm talking now broadly about vascular disease, coronary artery disease, peripheral arterial disease, we might be able to predict the future of that lesion. We know that, for example, that in the coronaries, it's more of a problem that we have plaque that is vulnerable, so-called vulnerable plaque that is more likely to rupture and cause a thrombosis and MI. We might be able to predict that with this kind of imaging, combination of merging imaging with your Thor program to merge the spatial transcriptomics and the histology with the imaging. So let's hear a little bit about how you're doing that, and a little bit about your technology and how you're going to merge your technology with Dr. Wong's.
Okay. Yeah, so I think after hearing about that foundation model and how rich that data is, I'm going to bring you to the Stone Ages and where we actually are right now when it comes to understanding peripheral artery disease and what we're dealing with right now. So I think that one of the issues is that our understanding of peripheral artery disease really hinges on the type of imaging we're using. And right now, our gold standard is X-ray angiography. So injecting contrast and looking at silhouettes on an X-ray, seeing, whether it's blocked or not. And that's really our gold standard. And that totally ignores the biology of the disease. And we were trained to think of peripheral artery disease as being the same as coronary artery disease and the vulnerable plaque characteristics like you were talking about and thrombosis as a result of that. But the vast majority of what I'm treating actually are these diabetic patients, renal impairment patients, and it's a distinct pathology. It's medial artery calcification. You'll hear me call it MAC. And it's very distinct from atherosclerosis. And even just that understanding makes a huge difference in terms of how we can actually approach it, because it's no longer just a mechanical obstruction, a plumbing problem, but it's really the biology of the disease where you have this mineralizations that are turning our arteries into lead pipes. And as a result, none of the things that we do to treat it will work. So we really have mechanical means of opening up these blood vessels, whether it's with lithotripsies or balloons. None of this works in medial artery calcification. Your stents won't expand, your balloons are going to pop, your drugs are not going to absorb when we're talking about drug-eluting tech. So we all know that if you have heavy calcification, that patient has a very high risk of failing your intervention and having a high risk of amputation. And so, we are so far behind when it comes to peripheral artery disease. And when we look and take kind of a cue from the oncology experience, I think it was a huge change when they started to go from mechanical means of just chopping out tumors to actually understanding the biology of the disease, when it can be targeted, and how do we do that in a personalized way. And so what if we do that with calcified plaques? I think that, that's one of the things that we're seeing, that not all calcium is the same, and there is this spectrum where you go from these really early stages that we can't see on our traditional imaging, but we can with some of the MRI techniques that we have. So I'll show a little bit about that. But basically, for us to really explore this, we needed something which is quite a unique resource, and that's our peripheral vascular disease biorepository. So every patient that undergoes an amputation for critical limb ischemia at Houston Methodist, we try to recruit all of them, and we actually image the amputated limb with high-resolution MR. We then either will harvest out the blood vessels and then do ex vivo high-resolution imaging with MRI and micro-CT, and then send that for histopathology. And then some of those we're now doing spatial transcriptomics on. So you have this really rich data source where from the same tissue, you have everything from the bulk clinical images to the spatial transcriptomics. And so this is something that we're continuing to build to train some of the models that you just heard about to see whether we can apply it to our patients. The first step was really just using the images to create the histology, because we've seen that Guangyu can, look at the histology and tell you a lot of detail, but first we need a non-invasive way of being able to get that histology. And so that's how we use our MRI. What you're seeing there on the left side are grayscale images. These are ultra-short echo time images of these blood vessels. And it can show you calcium, but different stages of it. So what you're seeing in stage 1, I'll kind of zoom in here, you see these really small punctate areas of calcification, and that starts to go to stage 2, where you start to coalesce into these islands, stage 3, where you start to have fragments, and then stage 4 is where you have circumferential calcium, so that black dark ring. And that's the lead pipe that you can see on an X-ray. So we can't see it until it is far progressed, but we're seeing that you can actually visualize these early stages of it earlier on. So, we're using some of the models that Guangyu's developed. So HiPath is one of them, where he's looked at our histology and looked at different kinds of segmentation for it. And it's outperformed some of the existing models that are out there for histology and tissue segmentation. We combined not only the histology, but with our annotations as well to make those predictions a little bit more accurate. And now applying it to the non-invasive images, so now you're able to segment those appropriately. And then we're doing the spatial transcriptomic analysis on that. So that's where we're looking at different stages of calcification and whether we can see, are there times where this is still modifiable or when it's irreversible? Because I don't think any of our mechanical means are going to be effective on these really late stage calcium. The only way to really address this is to prevent it before it happens. And even in this really small set, we saw that this is really striking to me, because I thought that once you've had calcification that causes kind of that medial artery hardening or osteogenic transformation, that, that was like a biologically inert and dead tissue, that there's nothing that you can do for that. But when we're looking at some of the transcriptomic features, we see that there is this, even in stage 3, a very strong inflammatory component. We see osteogenic programming. We're seeing some potential therapeutic targets here. And so it's really transformed how we're looking at calcification, not as some dead inert thing, but something that is on a spectrum and something that may be something that we can target in the future. and that's where the third aim will kind of bring this all together, taking the MRI images and how Guangyu's been able to use histology and predicts kind of the transcriptome from it. Can we do that with MRI images? Also feeding it with EMR data, other types of data to make this a really rich source, and then using that to predict some of the outcomes. I think that that's really where we're heading. What we're doing right now is not working. Our mechanical means for treating this, we still have 20 to 30% amputation rates in just a year. And so we really need to reevaluate what we're doing here. And if we're going to have any chance of saving more limbs and lives, we have to take a cue from the oncology teams and start to apply that to this really, really severe disease process.
Wow, that's so exciting. It went by pretty fast, but
Yes.
I did see, I loved how you talked about how calcification is an active process, and this osteogenic program is something that you were surprised to see, the inflammation and osteogenic program. One of the things that was elevated was TWIST, which is important in endothelial to mesenchymal transition, endo-MT.
Okay.
And that could potentially be involved in the cell fate transition that is that osteogenic program. So very, very interesting, and I think you will learn some things that are going to change our therapeutic approach.
I think it's just the more we're doing of this, the more complex it's appearing. But just even that fundamental understanding that this is an active process and something that's has some inflammatory features to it. It's just not something, even though we treat this every day and we deal with these blood vessels, we had no idea.
Well, how is this information changing your practice today?
Well, I think that right now we're kind of still, resting with the tools that we have. So we have the mechanical means. I am doing more things to change the compliance of the blood vessel rather than focusing strictly on debulking the blood vessel. So as an example, intravascular lithotripsy, it doesn't really take away the calcium like atherectomy might, where you drill it out, but it does change the compliance of the blood vessel. And it seems like that becomes more and more important. Things like that in terms of what are our goals with the procedures that we're doing. But really this is about the future and how we can take this further.
Dr. Wang, do you see a time when you can get an MR image of the leg and really understand the tissue at a molecular level?
Yeah, I think that is what we try to do here. And so the idea is we try to regenerate the 3D tissue. It's kind of in silically regenerate 3D tissue using both MRI image and the histopathology image and the spatial transcriptome based on the AI technology. So the general domain, the general domain field has been done. So currently, if you have several 2D image using your iPhone to have several image, and then run AM algorithm, so actually you can regenerate a 3D kind of object, but that is developed based on the normal image, so we can use our phone to take. So what we try to do is to input the pathology image and guide by MRI image, because MRI image is really like a 3D, and guide by MRI image, and train the model based on several 2D image to regenerate the 3D tissue. And after we regenerate 3D tissue, we will predict the transcriptome using our software.
So I'm very excited to hear your goal to do 3D reconstitution of the tissue. But my question is, so I can see that your Fuji method, the spatial transcriptome analysis method, is very suitable for like cancer, which has a very solid mass. You can just dissect the side that has a disease. But I think in vascular disease, we sometimes the tissue we have the disease site is not that even. So we can see a calcification here, but not anywhere else. So that will, I think that will depend on what is resolution, like what is maximum depth that it can perform such reconstitution without actually getting to the site that is actually calcified. So how can you like make the prediction? Do you have a limitation or resolution limitation that's it? I can only predict this much. Like and also it's kind of it's similar. Like if you look at the solid tumor spatial transfer, how can you predict metastasis? So something like that.
Yeah, I think that is why we collaborate, because for the resolution to us, we have the image. So we have several different aspects. First is whether the image resolution is high enough to observe the calcification. So if you use MRI, that is non-invasive, but the image resolution is not very high, not as high as pathology image. So we try to use this kind of tool technology to leverage each other. So pathology image has a higher image resolution, but not non-invasive. MRI has a low resolution, but non-invasive. So we try to put the high resolution information to the MRI image. And another aspect is kind of dimension resolution. So if you are using transcriptome, you have the whole transcriptome expression. So every gene expression you have. That has a higher resolution because the dimension is very high. So we try to further input the molecular kind of high resolution to the image further. And we will not stop at there. So we will keep adding more and more different layers of the data, like metabolomics, proteomics, and if in the future there are more data, we will merge them together.
Great. I also have a question to Dr. Roy. So I see with the collaboration between you and Dr. Wang, you get so much molecular biology information. So like the twist Dr. Cook just mentioned. So what's your plan to actually study whether this will work in your clinical setting? What's the plan? Do you have any plan?
I think that for us to think about like whether a therapeutic is going to work based on this, you absolutely will need good animal models for that. So we are starting collaborating with Dr. Huo's group in Baylor, and they have a mouse model that's where it's a kidney failure mouse model where they're able to induce calcification. And I think it is much more reflective of the medial artery calcification that we're seeing. And so that gives us a platform to maybe test some of these, theories. Because for us to actually know this, we're absolutely going to need good animal models in order to test those hypotheses.
Well, I think we've arrived at the end of a very stimulating conversation, and I really look forward to what you guys are going to do. I think you're going to change the world with this merging of clinical imaging and histology and AI, merging of the modalities. So congratulations on your work so far. Looking forward to see more. Well, thank you for joining us at the cutting edge of cardiovascular sciences. Our hosts today were Dr. Guanyu Wang and Dr. Tricia Roy of Houston Methodist Hospital, and we really appreciate your insights. Thanks so much.
Thank you.
Thanks for having us.